Okay, this is prolonged exposure therapy for PTSD. My goal will be to kind of talk about it as a review. This is more so to give you a heads up on what the protocol is and how it works. It is not a training for prolonged exposure therapy for PTSD, but instead an overview and workshop. So I want to talk a little bit about the theoretical history of prolonged exposure therapy for PTSD. I want to talk about the goodness of fit. I'm going to talk a little bit about the intervention and describe it, and then I'll do a small, short intervention demonstration. So we'll do a little bit of, I want to talk first about classical conditioning and operant conditioning. So classical conditioning is the Pavlovian conditioning. It is the putting one stimulus and combining it with another stimulus, meaning going back to his experiments, Ivan Pavlov's experiments. So he has a bell, and I'm going to make this very, very simple. It was a little bit different than this. But let's say he has a bell and he has a steak. He rings the bell and he feeds the steak to the dog. He rings the bell and he feeds the steak to the dog. What he notices is that when he rings the bell, the saliva is being produced by this dog, even if he doesn't feed them the steak. This is really important because this means that an automated response of saliva production becomes associated with a bell. So you ring this bell, and now you can produce saliva in this person. This is important for PTSD because it informs the production of unrelated stimuli to particular internal experience that's not necessarily controllable by the mammal themselves, right? So if he can ring a bell and produce saliva, then perhaps there are other ways in which we are environmentally conditioned that are we're not born with, but we experience as we go through the world, and perhaps even more so in a traumatic event. So we combine that with operant conditioning, so reinforcement and punishment. Oftentimes you'll hear positive reinforcement when we add something to make a behavior more likely, but there's also negative reinforcement, which it's a little different than the way they talk about it in pop culture. Negative reinforcement would be the removal of some burden to make a behavior more likely. So, what does that mean? What we're looking at is sometimes when we avoid something, it might reduce our anxiety and then reinforce that avoidance behavior. And that's where we get to Mauer's two-factor theory of learning, where we can learn by avoidance and then reinforcement of that avoidance. So we avoid and reinforcement of that avoidance. So if I have some phobia of, let's say, green shoes, and we'll talk about this a little bit more in our mugging, but I have avoidance of green shoes, then maybe anytime I see green shoes, I get anxiety and then I avoid it. You'll see my anxiety go down, and that's a form of reinforcement. So, what happens in the PTSD literature is we start to look at this concept of systematic desensitization. So, we're really trying to desensitize people to these reinforcers. And so, this comes back to this concept of Pavlov. He rings the bell and feeds the steak, and then he rings the bell and doesn't feed the steak, and the saliva still produces. But what's more interesting is what happens when you continue to ring that bell. Eventually, the saliva stops producing. And so what they learn in systematic desensitization, and the theory is antiquated now in comparison to common to contemporary theories, but still gave us a lot of information, which is if we do the same thing, if we engage with our phobias, then we can see the reduction of our anxieties over time because we've stopped pairing these two concepts together. We stopped pairing the if I have a phobia of green shoes, we stopped pairing the green shoes with danger because me being around it has slowly desensitized to me. Now, of course, this is an antiquated version of it, and we'll talk a little bit more about the contemporary theories. So, two theories that are really important to PTSD: the cognitive model of PTSD and the emotional processing theory. The cognitive model of PTSD is really about the beliefs and attitudes associated to a traumatic event that then leads to PTSD. I believe the last time I checked the literature, about 80% of people who experience a traumatic event recover naturally. So for those who go on to develop PTSD, we assume they get there through what the authors of cognitive processing therapy suggest is the process of assimilation, accommodation, or over accommodation. This was later brought into the cognitive model of PTSD through this concept of negative appraisals, meaning they appraise the world negatively. Um, but let's keep it simple and we'll talk about assimilation, accommodation, and over accommodation. So, assimilation is where we change the data in the traumatic event to allow us to keep a sense of our world beliefs, our core beliefs about ourselves or about people around us. So, um, this is whatever the event is, I'm going to end up changing it. So then that way, I can keep a hold of whatever belief structures I've already held on to. Accommodation is where we're slightly changing our worldview, adding some nuance into it in order to accommodate this new information that we've received from our traumatic event. And then over accommodation is an extreme change of our worldviews or our views about ourselves in order to fully encompass the traumatic event. Now, what is suggested is that most folks who end up with PTSD do either the assimilation component or the over accommodation component. Now, excuse me, the assimilation component would be I get mugged in an alleyway. I need to contain this world belief that I have that the world is fair and that good things happen to good people and bad things happen to bad people. So therefore, it needs to be my fault that the mugging occurred. So I need to start telling myself, I should have never been down that street in brand name clothes. I should have never been somewhere where people are so hungry or in poverty. I should have never been through a dark alleyway. I knew better. Everything has to be my fault if I want to continue to believe that the world is just, fair, and good things happen to good people and bad things happen to bad people. This is a common experience for folks with PTSD where self-blame becomes a heavy theme. Accommodation. Accommodation is what we're aiming for, because it adds some nuance into the beliefs into the fact of, well, I probably could be a bit safer when walking through an alleyway at night, or it was a bit unpredictable, but it's not such a common experience that it'll happen every day for the rest of my life. Something that adds a lot of nuance and allows me to continue holding some of my world beliefs, like the just world belief of everything, good things happen to good people and bad things happen to bad people, perhaps gets some nuance to it to the tone of if I do good things, mostly good things will occur. But sometimes bad things happen to good people, and that's just the truth of it. And then the over accommodation, that is where I am not changing anything about the traumatic event, but changing a lot about how I feel about things. And so it may be the world is unfair, the world is unjust, only bad things happen to good people, and it needs to be a dog eat dog world, and I'm a fool forever believing otherwise. And so that can also lead us to some PTSD conclusions because we've over accommodated on this event. Now, emotional processing theory, this is really the crux of prolonged exposure therapy for PTSD. So when we look at emotional processing theory and I'll say its sister theory, uh, inhibited learning theory, similar, a little bit different, but today we'll just talk about emotional processing theory. We look at fear structures, and when we say fear structures, what we really mean is like literal schema and maps for how to operate in the world once we have an activation of fear. So often you'll hear about fight, flight, freeze. In any particular event of fear or cues to a traumatic event. So how do we know what to do when we're covered in fear? When we experience fear, what do we do? What's the script? Well, these fear structures that we build through our traumatic events will tell us how we react at any given time for any given cue. And so we use these as roadmaps. But often these roadmaps can be inaccurate, especially in the context of PTSD, because we've now related an unconditioned stimulus with a conditioned stimulus. So getting mugged, maybe that's the stake in Ivan Pavlov's experience. That's the stake in which we're experiencing our own fear, and it's a justified fear. But then the person who mugged us is wearing green shoes, as we talked about a little bit earlier, we allude to. They're wearing green shoes, and now I have a fear and a phobia of green shoes that shows up that was not there prior to the traumatic event. And so I have a condition that stimulus to my kind of reactions and anxieties, where the anxiety then is the saliva in Pavlov's experiment. So our fear structures tells us what do we do in that moment of being cued to the fear. Okay, the fear cues us. Now what am I going to do? I'm going to avoid and I'm going to try to get out of this fear. Emotional processing theory tells us that we need to approach these cues, these objectively safe cues, in order to learn disconfirming information and alternative ways to comprehend the new cue. So what would I need to do? I need to hold a pair of green shoes. I need to go visit people who have green shoes. I need to go through the mall and walk around and experience people in green shoes. This comes to the safety behavior component. Safety behavior is despite its name, it's actually not a helpful behavior. A safety behavior is an unhelpful behavior that keeps the fear going through this reinforcement structure. So, whenever I have a moment of fear, my fear, it caps out until I hit my safety behavior, right? And so I interrupt that fear through a safety behavior. This could be alcohol. This could be leaving the room. This could be turning off a television that cues me of my traumatic event. It could be turning off a song that reminds me of something in my traumatic event. And once I turn it off, I can find some relief, and that relief in and of itself acts as a reinforcement for the avoidance. So it's circular in its reinforcing habits. And so, what happens when we don't engage in a safety behavior, when we don't avoid, when we just approach some stimulus on purpose? We see over time that that fear naturally subsides. So, we engage in the content of some stimulus, our fear will spike. But if we stay in it without engaging in a safety behavior, without engaging in avoidance, we will naturally see the reduction of anxiety. So, who's a poor fit for this treatment? Anybody who's currently in the traumatic event as it speaks today. So if you're in current domestic violence, if they're in current or actively engaged in combat, for instance, they would be a poor fit for this treatment. We're not going to go and engage with somebody who's in a domestic violence situation and do prolonged exposure therapy with them on a traumatic event that just occurred. That would be inappropriate. We really we want to work on what is their needs right now. And to be honest, if they're in an active domestic violence situation, we should be working on how to get them safe and work through that first and foremost. We also aren't going to work with anybody who's actively suicidal with an intent or a plan or is engaging in any behaviors of high risk suicidality. If they have a little bit of passive ideation, that's okay. But if they have an intent or plan or anything that's therapy interfering and dangerous, that needs to be number one priority. And PTSD treatment needs to take a back seat to the active suicidality, the emotional regulation, and the ability to keep themselves safe between sessions. Any other therapy interfering behaviors would be a poor fit for treatment, at least right now. We may kick the can down the road a little bit because what we're really wanting to do is reduce those therapy interfering behaviors. If they're showing up every other session or they're late 45 minutes to session, or, as the next bullet point points out, they're intoxicated during session, they're really not wanting to engage in therapy in a traditional manner. These may be things that you want to socialize through before you start the prolonged exposure therapy. If they're intoxicated in session, like I said, that's a really important, and I want to go more into that because it undermines the disconfirming experience. So their learning is interrupted. So this may include if they're using benzodiazepines, if they're using alcohol, if they're using cannabis, while they're trying to engage in the stimulus, you may be really undermining their ability to learn new information. And so it could be very unhelpful to engage with it that way. So the suggestion would be no intoxication during the time of the imaginal exposure and or homework exposures. Also, if they have no actual memory of the traumatic event due to brain injury or intoxication, if they were drugged and then the event occurred, it would be unhelpful to try to get them to remember memories that they just don't have because they weren't awake for them or they weren't conscious for them. Or if there is an organic brain injury that just made it impossible to remember, that may be also another reason that they would not be a good fit for imaginal exposure in and of itself and prolonged exposure more generally. If they outright refuse, this is not a coercive treatment. This is not something that we push or force people into. And I think sometimes pop culture can make exposure therapies seem that way, but in my experience, it's totally the opposite. It is um, I'm looking for somebody who has an enthusiastic desire to participate and wants to tell their story, because that's really what this is about. How do you build space and time for somebody in a methodical way to tell their story in a meaningful environment for them? So, who's a good fit for treatment? This may seem counterintuitive, but somebody who actively avoids telling their story, somebody who hasn't had the opportunity for a myriad of reasons. Maybe they feel like they're a burden on other folks, so they don't want to tell them. Maybe they think that they're going to hurt other people with their story because it's so intense, or maybe they feel like they're going to open up and never be able to shut back down again or shut off those emotions again. Those could all be true, and that person's an excellent fit for treatment because we can actively see somebody who has been avoiding a cue and we know what that cue is and we can address that cue in session of that memory. So they also need about at least, well, not about, they would need at least 6 months since their last relevant trauma event. Why this is important is because um, that's the criteria for PTSD. We got to remember prolonged exposure therapy is for PTSD, not for trauma. Trauma doesn't always lead to PTSD, and prolonged exposure therapy is a treatment for PTSD, not trauma. Most people recover naturally from traumatic events, so that's an important thing. So when we're using this, we want to be gearing it towards the disorder in which it was designed. Um, Also, if they're emotionally activated by the content of the story, the more emotionally activating, the better the prognosis has been pretty consistent in a lot of the literature for prolonged exposure therapy. So it's helpful that it's emotionally evoking content. Um, there is some nuance around whether there's avoidance happening that's leading to under engagement or over engagement in session. That would be addressed in a longer, more robust training for PTSD if you or for prolonged exposure therapy if you choose to go down this road. But generally, I want to speak to the content should be emotionally activating. They also need to be willing to complete the treatment and fully aware of the difficulty. Other therapists go about it different ways, but for me, I give clients a lot of outs before we start in order to really reedify their ability to say no if they don't want to do it. The ball's always in their court, so I often, will say multiple times, okay, now that you know what you're in for, do you still want to do this? Does this still feel like something that you're open to engaging in? Um, and we really want to see them go all the way through once they've started because we don't want to accidentally engage in more avoidance behaviors by encouraging them to stop partway through in this exposure process because that just becomes one more safety behavior that we're sort of reinforcing in therapy. Other more dangerous behaviors are under control. So, like I said, if they have those dangerous behaviors, they may not be a good fit for treatment, but that's really uh, in this moment in time. If those behaviors subside, then they may become a good fit for therapy. So the suicidality has gotten under control, and you feel like they're able to get from session to session pretty safely. Their excessive drug use or alcohol use is under control, and they can be sober in session or during homework without significant interference. Then it's probably okay to start moving towards this treatment as a fit. Um, session overview. So we're going to talk a little bit about what these sessions entail. Sessions are variable and they're dependent on need and protocol. So the following are real estimates. In my experience with the treatment manuals and generally with prolonged exposure therapy, you're customizing it to really fit with the client and their needs without reinforcing avoidance. So you're customizing it, but you're not reinforcing that avoidance. So sessions 1 through 3 may be in orientation and education. It may be uh, starting the priming process of what prolonged is and why it might benefit them. And you may also start getting into some of more education, which I'll talk about in the next slide. Session through 2 through 11 will be that imaginal and in vivo exposure. I'll talk about those at length a little bit more, but imaginal exposure is the telling of the story, reimagining the trauma event as part of that exposure exercise. And then in vivo exposure is in life. It's Latin for in life. So it's your in life exposure where you're actually out in that real world facing cues that are objectively safe, but do spark that anxiety experience. And then session 12 or the last session, just depending on how you've timed it out, will be where your conclusions and goodbyes occur. In some protocols, they'll even encourage you to give certificates of completion where you really celebrate the accomplishments of the client through this process. So, the orientation and education sessions, you're going to teach the client about exposure therapy and basic concepts of exposure therapy, the theories behind it, how it works. We'll also do a little bit of breathing retraining, which is the diaphragmatic breathing or belly breathing, as we say it often to the public. So, belly breathing may be um, where you're breathing in and then out. But what you want to notice is that your hand is on your belly and you're feeling it move up and down, and that'll cue you that you're using your diaphragm for the breathing. Why breathing is so important is because what I've often experienced in session personally is that when people are going through an exposure, if they hold their breath during intense moments or they're hyperventilating, you'll see their heart rate raise. And as their heart rate raises, they may have an inability at that moment to differentiate between their heart rate being raised because they're in high distress from the cue of the exposure or whatever we're working on, versus the just the breathing, the erratic breathing actually raising the heart rate, and it's not wholly tied to that cue. So having that breathing under control can help us focus mostly on the stimulus and not artificially raise our heart rate. Also, we maybe also talk about orientation to CBT and kind of behavioral therapy, homework and structured therapy more generally, prolonged exposure therapy, cognitive processing therapy. They tend to be some of the most structured cognitive behavioral therapy treatments. Many people assume cognitive behavioral therapy, if they're not familiar with it, is always highly structured. I would say that's not always true. Some of it is more process based, some of it can be very fluid cognitive therapies. But if you're going to have a structured therapy, prolonged exposure therapy, and cognitive processing therapy, as sister therapies, I consider them, will probably likely be some of your most structured and methodical as you go through this. You may also want to do a possible practice session. It can be helpful at times to encourage somebody to do a benign memory as a practice session. So let's go over your breakfast this morning or something to that effect. And what this will do is it'll allow us to coach them on the level of detail we're looking for, really get into like that intensity of the detail. And then it'll also allow us to talk a little bit about SUDS, which we'll talk about right now. It'll allow us to get into that subjective unit of distress scale, what that means, and really coaching them on how to give us their number, as we'll talk about in a second. So we'll introduce the subjective unit of distress scale, or SUDS as we call it. This is a scale that goes from 0 to 100, 0 being zero, no distress. I don't feel anything. I often joke like, oh, I'm sipping Mai Tais on a beach somewhere. That's my 0. At 100, it is I'm right back in the traumatic event. What's important too, and what I've noticed is that you sometimes need to coach them on that the SUDS number that they're going to give you. I'm going to give you my, I'm going to ask you for your SUDS number. It's not what did you feel like when you were during in the traumatic event. It is how do you feel right here in this room or in this session describing the event. So that's an important differentiation to make because sometimes the client may misinterpret your request as you want to know how much stress they were in while they were experiencing that. But that's not the goal. The goal is we want to know how much stress you're experiencing in the here and the now as you tell the story or engage in some stimulus. So, this is a client self-rated level of the stress, so they are using it based on their subjective feelings. So there's no right or wrong answer. It's just how much stress are you in. If 100 was you right back in the traumatic event again, and zero was you at your most relaxed state. And they're going to be reporting it. And these are really important because it helps us see progress over time. It helps us get a sense of maybe where the most distressing moments in the either imaginal exposure or in vivo exposure exists. It also helps us find these things called hotspots. Hotspots are parts of the memory that are more disturbing than others that sometimes we will fragment out of the rest of the memories and will encourage them to do multiple exposures on simply a small section of their memory, as opposed to the overarching sections of their entire memory. But again, you would go over that in a longer training, which I would suggest if you're finding this interesting, I would definitely encourage you to look into trainings more in depth for this. In vivo exposure, in vivo is Latin for in life. So these are exposures of the physical environment or stimulus that are objectively safe. I consider YouTube even and songs and music to be in vivo exposures. So it's anything in the physical environment, and sometimes, in my opinion, the digital environment that may be helpful to cue these experiences of emotional activation that we are then engaging in on purpose while keeping the safety behaviors out of the room so we can learn this disconfirming information. Remember, this is all about learning disconfirming information. These cues are not dangerous. My emotions are not dangerous. I'm here to build competency over these emotional experiences. Um, so they could be objects present during the trauma, or maybe even people who resemble perpetrators. So often men are violent people, and like that's just what it is. Like so much of violence is done by men, and I feel like I have the right to say that as a male myself. And so I can say that many survivors of traumatic events may benefit from finding objectively safe men who cue them to their anxiety. So, for instance, maybe they have a coworker who spikes their anxiety because they resemble somebody in their past who perpetrated an event. It may be part of their in vivo exposure. This is always with their consent and always with their enthusiastic engagement that they may invite this person to lunch eventually over a long period of building out a hierarchy and working through an in vivo exposure plan. Clients should predetermine the length of the in vivo exposure prior to engaging to refrain from avoidance behaviors at the peak of distress. So, what we don't want to do is we don't want to go, okay, you're going to do this in vivo exposure until you just feel like not doing it anymore, because that could lead to um, an issue in which they are leaving at their highest point, recreating a reinforcement of avoidance. They used to, old protocols, I believe, if I'm remembering correctly, used to say don't leave the exposure until you drop 50% of the suds. The issue with that, I think, becomes practicality and pragmatic. You may be there for too long to make it realistic. And so instead, what the suggestion would be is you set a time in session. Okay, I can do that for 5 minutes. I can do that for 10 minutes. I can do that for 25 minutes. And then we would go and engage in the in vivo exposure. They would probably do it by themselves, or if you have a practice that's built for this, you could do it with them. Y'all go and do the in vivo exposure, and once the in vivo exposure is timed, then they exit the in vivo exposure and record their SUDS afterwards so we can start seeing progress on it. They probably do the same exposures again if as an opportunity to see progress. Simultaneously, you may also increase the time that they're engaged in these exposures if they are feeling like that would be a useful way to engage in these in vivo activities. Imaginal exposure is using descriptions of the memories or, in some cases, future fears as a method of exposure. When we talk about future fears, it's very often other types of exposure, not so often prolonged exposure therapy for PTSD. You'll often use imaginal exposures for other types of phobias or anxieties. It could be possible to use it in PTSD, but more often we're going to be talking about a historical recount of their traumatic events. And so we'll be describing in great detail the nature of the feared scene. So we really want to dive down deep into the details. And then the client reports SUDS during the exposure exercise in session. So they'll literally be talking and somewhat rudely, I'll be honest, I'll interrupt and I'll say, what's your number right now? And they'll say, 75, 80, or whatever it ends up being. And then we'll record that over time is a way to catch the intervals. Uh, I believe protocol says request that every 5 minutes. I've found it personally useful to adjust the timing of it based on the length of the narrative. I've also found that the narrative length changes as people engage more in their memories. The details start to come up more, so they start to remember things that they didn't remember than the very first narrative, which allows for the extension of time in the imaginal exposure, but also the extension of detail in the imaginal exposure. So that's important, in my opinion, because I think the first narrative is likely to be smaller than the last narrative, and that's just been my experience on multiple engagements in this treatment with folks. Um, the client is asked to repeat the imaginal exposure multiple times per session across multiple sessions. So three times per session makes sense to me generally. Often that's what the goal is for me. I often encourage 3 times per session. I'm totally fine with 2 times per session, and I would like to see at least 3 sessions of imaginal exposure. More is great. Less, it gets shaky because the literature suggests that even one dosage of imaginal exposure can be helpful. So I wouldn't discourage somebody from it if we're going less than 3 sessions at this of imaginal exposure specifically. But I try to really encourage that 3 sessions of imaginal exposure with 3 dosages, as they call it. They call them dosages every time you tell the story, with 3 dosages of that imaginal exposure. So in a bare minimum, my hope would be that we've told that trauma narrative 9 times over the course of therapy. Um, and then the client records the sessions and listen to it as homework. So this could be different depending on what you have access to. Some clients may feel comfortable recording it on their smartphone or their device, and they feel safe with it on their device to listen to it on their own through that means. You may also purchase a tape recorder and put it inside of a HIPAA bag and give it to them, and they can take it home with them. That's how some of the older protocols were before smart devices were available as widely as they are today. So I think that that's a technology thing that you can work out through either through your client or through purchasing a tape recorder. So what does the session structure look like? What does it actually look like when you're in prolonged exposure therapy? Like, what is you doing logistically moment to moment? So you'll probably do a check-in, 3 to 5 minutes. How was your homework, or how was, things in between the last session and this session? Then you'll start the recording again, either your device or smartphone of some type. And then we'll do an imaginal exposure that usually ranges from 30 to 60 minutes. In my experience, I think that also depends on their emotional activation and the length of the narrative. So that's what makes it different. But yeah, 30 to 60 minutes. and then the processing of these experiences. So often, I think there could be sometimes unjust criticism towards prolonged exposure therapy for being all exposure focused, but actually the processing of experiences is really important because that is where some of the cognitive restructuring can occur. Cognitive restructuring, of course, I'll talk more in other videos, but cognitive restructuring is this process of really changing attitudes and beliefs to help them become more accurate and more healthy towards worldviews in the self. And so this is where you can kind of engage in that process of experiences. In my opinion, though, and this is just my opinion, I suggest not doing too strong of cognitive restructuring at the beginning because during the first processing of experiences, because so much of this experience is going to be new that just allowing them to talk out loud and flush out some of their ideas and thoughts is going to be helpful. So often, especially in those first 2 or 3 sessions of imaginal exposure, I'll find myself doing more of almost like a person-centered active listening style of engagement in order to let them kind of reflect on what they've experienced throughout the imaginal exposure. And the what am I doing in processing is often just what was it like to tell the story in order to kind of prompt that engagement. And then you're going to assign homework, which could be the in vivo exposures and or listen to the imaginal exposure or both. And so we're often encouraging them to listen to that every single night. If they're up for it, I think that's really helpful. Get them to listening to the imaginal exposure and recording their suds, but then also doing the in vivo exposures outside a session as well. Both of these can have real heavy impact because you're taking a therapy that they were doing once a week and you're now making it, up to 7 days a week, which can be a real positive impact on their progress and the pace of their progress. So in the workshop, when I do it live, normally I pick a volunteer, but instead, because it's just me and I guess you here, I'll do the memory. So I'll play a little bit of both sides, but basically we would be prompted into like start the memory about 5 minutes before the actual event occurs. But right now I'm going to do a benign memory just to walk us through what it might look like to hear an imaginal exposure. So I'm going to pick something that is relatively low stakes, low injury. So you don't need to worry about the content of the trauma right now, just listening for the level of detail and where I might give out some SUDS number of some sort, right? So um, let's do breakfast this morning. We'll go over breakfast this morning. So I start by walking down my stairs, and my stairs are carpeted. And so I remember keeping my left hand on the railing. The railing is made of a wood grain, and I'm holding the railing as I'm walking down the stairs with my left hand. I'm pattering my feet across the carpet and actually I have slides on now that I remember. I have slides on, shoes, and I often wear these in the house. So when I get down to the bottom step, I step down and make an immediate left and I walk into the kitchen. As I'm walking into the kitchen, I walk past the island and I move towards the back of the kitchen, which is connected to the garage door, the entrance to the garage door. And on my left is the cabinet. I open the door with my left hand to the cabinet where I keep, bowls for oatmeal. I'm gonna make some oatmeal, but there was no bowl there for me. My suds. My suds are say a 40 right now. And so I close the cabinet and I turn around and I realize the dishwasher still has, clean dishes in it. So I open up the dishwasher and I pull out a bowl to make oatmeal with, and I turn around and I set it down on the counter. I grab a packet of instant Quaker oats oatmeal and open it up, and I tear it along the line that it says. And I pour it into the bowl, and then I grab a Brita filtered water filter thing like a carafe, and I pour just enough water into that fill line, and then I pour it into the oatmeal. Okay, I'm not going to keep going through that whole thing, but that is the level of detail that we are looking for when we are asking them to do imaginal exposure. And so you can imagine how impactful that is as they are describing some of the most traumatic and tragic moments that they've experienced in their entire life. And so in that, we are going to be looking at real intense details. So my encouragement to you is to one, to get that training, two, to pick up as many manuals on the subject as you can, and three, you cannot be afraid of the content itself. It'd be really important that you engage in the content. Meaning, if if you have some traumatic memories that you're still avoiding, it might be best for you to first do your treatment yourself before you do it for other people, so that way you don't accidentally get evoked inside of the session. And also, I think, and this is really important for me to say, I believe, if you do not feel comfortable doing this treatment, that does not make you a failure of a therapist or a therapist who does not know or can't handle it or anything like that. I think this treatment does not need to be a treatment that every therapist does. It's just a treatment here. If you're somebody who wants to specialize in PTSD, it's a great treatment to do that with. And if you feel comfortable hearing these stories and engaging in these stories, it's really, really beneficial for people. And not only does the data show that, but my personal experience is that people really recover from therapies like this. So I really encourage you to do it. I also have some books here that I would encourage you to read. Uh, here's the therapist guide for prolonged exposure therapy for PTSD. Here is the workbook that the client can engage in for PTSD. Here is the concurrent treatment of PTSD and substance use disorders. So if you work with somebody in outpatient, you can encourage them to do both substance use and PE at the same time, or prolonged exposure therapy, often shortened to PE. And then here's the workbook for them who may want to do that outpatient SUD and prolonged exposure. Here's one for an IOP. So if you want to do PE as an IOP, that's a really interesting way to do it, where you kind of do it in a fast-paced setting where you're doing more prolonged exposure therapy more often through the week and doing some of the psychoed and some of the other group work. Cognitive processing therapy is also it's an alternative to prolonged exposure therapy, but I think it should be something that should be highlighted. And I will also do a video on an overview of that. But cognitive processing therapy, it is highly effective as well and focuses more on attitudes and beliefs and the cognitive restructuring aspects than the exposure aspects, but it still has some exposure elements for at least the CPT with accounts protocol. Now, they have a new edition, so the cover looks a little different than it does right on this slide deck. Also, treating trauma and dialectical behavior therapy. There is a protocol that combines DBT and PE. So, if somebody is in a psychiatric setting or is in 24-hour care for suicidal ideation or something to that effect, or is often engaging in non-suicidal self-injury, this might be a great way to engage that person because this speaks about how to first regulate the person and help them get into some kind of safe consistency before engaging in the prolonged exposure therapy. And then there's also, it's not up here, but there's the STARE protocol, which is another combination of prolonged exposure therapy and uh, um, coping mechanisms for folks who have emotional regulation concerns. So yeah, this is the workshop. Feel free to comment down below if you have questions. Otherwise, thank you for tuning in and hope to have more videos for you here soon.